Dear colleagues, welcome to the EACVI webinar on how to use multimodality imaging for transcatheter aortic valve implantation. I'm Dr. Victoria Delgado from Leiden University Medical Center. The aim of this webinar is to give you a better understanding of the relevance of multimodality imaging to diagnose aortic stenosis and select patients for TAVI, as well as how to use imaging to guide the intervention, predict complications, and how to treat them. Those cases will be presented by Dr. Mark Monaghan from King's College in London and Mark Dweck from University of Edinburgh. At the end of this 60 minutes live event, you will be able to select the various imaging modalities to get the diagnosis of severe aortic stenosis right, how to select patients for TAVI and use multimodality imaging to optimize the procedural results and minimize the complications, and to understand the acquisition and post-processing of 3D datasets. This session is highly interactive, and we strongly encourage you to actively participate by sending your questions and your comments at any time during the webinar through the chat. And for the best learning experience, we also invite you to participate in online assessment sessions in the form of multiple choice questions that will be submitted during the presentation. Anything you need to know, just ask, and we will provide you tips and tricks for your daily clinical practice. Now, I will hand over Dr. Mark Dweck, who will present the case.
Okay, thank you very much, Victoria. Hello, everybody. It's a big pleasure to be here. So I'm going to kick off with a case, a patient that I looked after and first met a couple of years ago now, actually. But I think it's an interesting case and provides a good illustration of how we can use different imaging techniques to try and assess our patients in the lead up to TAVI or surgical valve replacement. So we'll kick off. And the patient is, we'll call her Miss X. She is a 74-year-old lady, and she presented to the hospital with a history of increasing breathlessness that had crept up on her over a period of several weeks and was now bad. She was breathless at rest, on minimal exertion, and was feeling unwell. She did not describe any chest pain and had not had any syncopal or pre-syncopal events. Her past medical history included a diagnosis of multiple sclerosis, but this was under good control, in remission, and she was a heavy smoker with a diagnosis of COPD and an FEV1 of 1.8 litres. So we examined her, and her blood pressure was a bit on the low side at 90/69. Her pulse was 68 beats per minute and regular, and she was quite a frail lady. She weighed only 40 kilograms. On examination, we found that she had features of congestive cardiac failure. She had a raised JVP, she had crepitations to her midzones and bilateral ankle edema, and she had a very clear ejection systolic murmur. We did an ECG, and this showed sinus rhythm with left bundle branch block and a broad QRS complex. And she also had some runs of non-stained VT on the monitor. And we did a chest X-ray, which is shown up on the screen, and as you can see, there were features of bilateral pleural effusions and pulmonary edema. So the next step was what we do when we're concerned about patients with heart failure, and particularly ones who have a murmur, was to perform an echocardiogram. And this is an image from that echocardiogram, a transthoracic echo. And as you can see, the left ventricular function is depressed. We thought it was severely impaired, with clear evidence of dysynchrony in keeping with a left bundle branch block. And you can also see that her aortic valve is thickened, calcified, and restricted in its opening. So this was assessed in more detail with Doppler echocardiography. And we found that the peak velocity was 3.8 meters per second, and the mean gradient was 38 millimeters of mercury. But she had a low flow state, so given her low and impaired systolic function, she had a pre-valve velocity of just 0.8 meters per second. So in total, when we assessed her and we saw that her aortic valve area was 0.6 centimeters squared, our impression was that she likely had the so-called classical low flow, low gradient aortic stenosis, severe aortic stenosis. But having said that, the echo measurements were discordant. It wasn't completely clear cut. So, putting that all together, I think we really had two clear questions in our mind. And the first was, what is the mechanism of this lady's left ventricular systolic dysfunction? Is it related to her valve disease, or is there another pathology that has caused it and contributed to her cardiac failure? And the second question was, does she have severe aortic stenosis? I guess linked to the first question. But we wanted to make sure that we had the diagnosis right from the echocardiography. So with these two kind of clear clinical questions in mind, time for you to do some work. So what do you think would be the next best imaging test? And there may be some debate about this. There's not necessarily a clear-cut answer to this, but the possible answers that we've put up for your perusal: first, a valve stress echocardiogram. Secondly, a cardiac magnetic resonance scan. Thirdly, a CT scan with calcium scoring. Fourthly, a repeat transthoracic echocardiography. And finally, a transesophageal echocardiogram.
So, very challenging case that we indeed find in clinical practice, and it's a very relevant question, both of them. One, when the patient has heart failure, to know which is the etiology of this heart failure, and second, when the patient comes with an aortic valve that doesn't open, if that is really a truly severe aortic stenosis or not. So the question to you was which imaging technique to use now as a next step. And I can tell you that the audience has voted, and most of them, 55%, would use stress echocardiography, 21% transesophageal echocardiography, and 13% CT calcium scoring. What you did?
So it looks like I'm a lone voice here, but we didn't go for any of those. We went for an MRI scan. And I guess stress echocardiography was right at the top of the list of things we wanted to do. But we were a bit concerned about this non-sustained VT on the monitor that we captured. And we were concerned about giving this lady dobutamine stress. So we elected to do an MRI scan, and I'll show you the pictures. You can tell me at the end of this whether you think this was a useful test or not. So this is a classical three-chamber view of the heart and the valve. And you can see that the valve is thickened. The images are similar to the echocardiogram. There's a clear acceleration of flow at the level of the aortic valve, consistent with aortic stenosis. And again, we have severe left ventricular systolic dysfunction with quite marked asynchrony there. There's no clear regional wall motion abnormalities or areas of wall thinning. If you look at the image over here, we can see that the pattern of opening looks a bit like a bicuspid valve with fusion probably of the right and left cusps. And in the middle, this is really what we did the MRI scan for, was the late enhancement imaging. And so we're trying to look at the myocardium and work out, well, what's the etiology of the heart failure? And I think the thing that stands out when you see these images is that there's very little scarring. This is not a patient who has an ischemic cardiomyopathy with multiple previous infarcts as the cause of her LV dysfunction. And so neither does she have clear features of cardiac amyloidosis. There is perhaps a little bit of scarring here down at the insertion point that you often see in patients with advanced aortic stenosis. But overall, our impression was that generally this myocardium was viable. There was a lot of healthy myocardium that we thought likely this is due to her aortic stenosis, and more importantly that this is likely to recover if we replace the valve, and that we should move forward in that direction.
So with CMR, you have defined the etiology of that heart failure. You know better the function of the ventricle. You know that there is no scar, but still, does it answer the question whether this is a true severe aortic stenosis?
Yeah, I don't think it does. But I think what it gave us the confidence to do is to move forward to the next phase of investigations. And we thought that this patient, we should be at least considering TAVI in this patient. She's frail. She weighs 40 kilograms. She has this history of smoking and a diagnosis of COPD. And so in the workup of patients towards TAVI at our institution, we generally turn towards CT. And so that's the next test that we did. And when we were planning the CT scan, we wanted to know, as you said, is it truly severe aortic stenosis? And so we did a non-contrast CT calcium score to help us work that out. And we'll talk about that in a bit more detail in a second. And then secondly, we wanted to assess the potential suitability for TAVI versus potential surgical approaches. And so we were going to make the valve measurements, try and size potential valves, look at access routes, and again, look at the position of coronary arteries and the ostia. So first of all, the CT calcium scoring. So is it truly severe aortic stenosis? Well, it can be difficult in patients with low flow status, particularly if you can't do stress echocardiography, as we felt was the case in this patient. And so an alternative that has emerged is CT calcium scoring. So this is a completely different approach to echo. It's not dependent on the flow status of the patient. It's basically an anatomical test. And it relies on the idea that patients with aortic stenosis, the predominant cause of the valve narrowing is calcification. So if we quantify that calcification, that can serve as a marker of disease severity. And it's been validated in several large studies now, and we have cutoffs that we can use. So they're interestingly different in men and women. And in men, we use a cutoff of 2,000 Agassiz units to define severe disease. And in women, it's lower, it's 1,300 Agassiz units. And studies have now shown that these cutoffs have good diagnostic accuracy compared to echo. And also they offer powerful prediction of both disease progression and clinical events. So we use this increasingly in our patients with aortic stenosis, particularly people coming through the TAVI service who are getting a CT scan anyway. We add that to our protocol, and that can provide us with added information without too much hassle or expense for the patient. And it is now supported by the latest version of the ESC guidelines. And this is not for everybody, but in the patients where first-line echocardiographic assessments don't give you a clear answer, perhaps they have discordant measurements, as we saw in our case, then you can consider CT calcium scoring alongside other techniques like stress echocardiography to help you differentiate severe from non-severe aortic stenosis. So we did that in this patient, and sure enough, her CT calcium score came up above the threshold of 1,300, and so we were then confident that this patient has severe aortic stenosis and also has a ventricle that's likely to recover following valve replacement, and that we should move forward with valve replacement. The next question, though, is how are we going to do that? Are we going to use TAVI, or are we going to go for a conventional surgical approach? And so then the CT gives us some more information in order to be able to answer that. I think the key step when you're doing a CT scan for these patients ahead of their TAVI assessment is to get into the true plane of the valve and to make measurements of the annulus and the LVOT. So what is the annulus? Well, the annulus actually is a very complicated structure. It's this structure up here, this coronal type structure where the valve is attached to the aorta. And so that's a complex thing for us to look at. But what we instead do is with imaging, we define the annulus basically as the bottommost part of each of the cusps of the aortic valve. And we join those areas up in a circle and use that for our measurements. So this is an example of how we do that with the CT scan. We can get into the true plane of the valve by reorientating the different views, coronal and the sagittal views. And then we can make sure that we have the annulus, the point where all three cusps first come into the view, and then we can start to make measurements along this axis. A lot of the modern software platforms now do this in a kind of semi-automatic manner, which makes it pretty straightforward and easy to do, and I think opens up this technique to lots of different people who are interested in making such measurements. So this is an example of a patient. I think one of the key things that we've found out from TAVI is that the idea that the annulus and the LVOT are not circular structures. In fact, they're elliptical. And so the importance of that is that if you make two-dimensional measurements, whether that's by echo, transesophageal or transthoracic, or indeed MRI, then that can mislead you. You may underestimate the true size of the annulus, and better is to take maximum and minimum diameters, and also to look at perimeters and the area of the LVOT for sizing. And Mark's going to talk about that in more detail later on. We'll come back to that, but I think that's a key message from this webinar, that you have to make measurements using 3D data sets. So we did that in our patient, Mrs. X, and the measurements are shown below. We thought that the patient was probably in the range of a 29 millimeter TAVI valve if we were going to go down that route. So you can then do other assessments. So we can take measurements across the sinuses. We can look at the morphology of the valve. Here, I think we thought that the patient had a functionally bicuspid valve, again with fusion of the right and left coronary cusps. We can take measurements of the sinotubular junction, and we can take measurements of the distance from the valve to the coronary arteries to make sure that we're not at risk of blocking the coronary arteries during TAVI deployment. And then finally, we can tell the operators the optimal angle for them to set up their X-ray equipment in the cath lab so that they are exactly coaxial to the plane of the valve. So I think all of these measurements are useful and what we routinely provide in our assessment. The other thing that we can do is beyond the valve and the heart is we can look at the peripheral vasculature. And you can get very detailed images of the iliofemoral vessels and the vessels higher up in the body. And we can start to make measurements. So we can look at the diameter of the vessels, we can look at tortuosity, we can look at the degree of calcification, and using a combination of these things, decide whether a femoral access is feasible in these patients. If we don't think it's feasible, we can look at the subclavian arteries as well on the same scan, start to make similar measurements, see if we can do it from that access route. And if it's not feasible on that, we can start to plan transaortic access. So back to our patients, this is what we found when we looked at peripheral vessels. The right and left system were pretty similar. And what we basically saw was that Mrs. X had pretty smooth looking peripheral vessels. There wasn't much in the way of stenosis or calcification. They weren't particularly tortuous, but they were small in caliber, really at the borderline of what we would consider suitable for TAVI, 5 millimeters on the right, similar dimensions on the left. So we've got a lot of information now. We've done 3 different imaging tests, an echo, an MRI scan, a CT scan. We think this patient has severe aortic stenosis. We think their ventricle is likely to recover if we replace the valve. And so we have some treatment options that we need to consider and decide upon what we think is the best course of action for our patient, Mrs. X. So these are the 5 options. It's over to you again to make a decision. What would you do next? What treatment would you offer our patient? The first option is transfemoral TAVI, perhaps under local anaesthetic. The second is a surgical valve replacement using a bioprosthetic valve. The third is a transaortic TAVI. Fourth, we could consider medical therapy. And finally, consider surgical aortic valve replacement with a mechanical valve.
So this is the next question for you, and indeed these are the questions that come every day into the heart team discussions. And for these patients, as Mark said, is a patient with COPD, frail, severe aortic stenosis, left ventricular systolic dysfunction, and peripheral arteries that are borderline. So the audience has answered, and well, there is a 50-50 between transfemoral TAVI and transaortic TAVI. And I think that here it comes the question now that the procedure has been very much simplified and you can do without general anesthesia, whether you intubate in a patient with COPD or you do transfemoral without the need for intubation. What do you think, Mark?
Well, I mean, out of those 2, which I think is what it really does come down to, because surgery is clearly discounted this patient, transfemoral TAVI could be done under conscious sedation, and with her impaired lung function, I think everyone would want to avoid a general anaesthetic. Now, I agree that peripheral vessels are a bit borderline, but I suspect that most interventional cardiologists would want to give it a go at least and see whether they can attempt it that way before thinking again. So.
Well, that's exactly the conclusion we came to. The interventionists were keen. They weren't put off by the borderline peripheral vessels, and they recommended transfemoral TAVI, and that's what happened. So this is our patient having that transfemoral TAVI. We did it under local anaesthetic. The patient didn't need a general anaesthetic, which was important, I think. We used the left femoral artery and implanted a 29 millimeter Evolut R valve, so a self-expanding valve. We were delighted that following the procedure, despite the pre-existing left bundle branch block, the patient avoided the need for a permanent pacemaker. We thought that was a good result. We were happy. And the femoral artery puncture was uncomplicated. It was closed with a ProGlide suture, and there was only a trivial amount of paraprosthetic leak at the end of the procedure. So really, we were very happy with how that went, and the patient did extremely well. She felt better soon after. Her blood pressure came up. She was able to mobilize around the ward, and we discharged her home after just 3 days. She was on a small dose of diuretic therapy, a bit of an ACE inhibitor to try and help her reverse remodeling and a return of her LV function, and we got her home. So that was a great result. We were delighted, but unfortunately, she came back a week later, and this time she was complaining of pain in her left leg, the lateral aspect of her left leg, and she was having that on exertion, but now equally she was having pain at rest lying in bed. And we were concerned about this. We got her into the hospital, we assessed her, and we couldn't feel any pulses in her left leg. So she goes for another scan. And again, we used a CT scan in this instance, looked at the peripheral vessels. And you have to look pretty carefully at this. But as it screens through and you look carefully at the left side, the left iliofemoral vessels, we can follow them here. You can see the contrast in the vessel that disappears. And we've got an occlusion of the left femoral artery. It's only a small, quite a short segment that's occluded. And so we had a discussion with the vascular team. They came to assess her, and they were happy to take her forward for an operation. She underwent successful endarterectomy with clot removal in the left femoral artery and did extremely well. That her leg pinked up. She was able to walk around without any symptoms and has been fine ever since. And in fact, more generally, she's one of my favourite patients that I see in the clinic, because every time I look at her echo, I just feel kind of happy to see her left ventricular function almost back to normal, really. She still has left bundle branch block. There is some dysynchrony. On other views, it looks perhaps mildly impaired. But really, she has done extremely well, and perhaps most importantly, symptomatically, she is much better. So she doesn't really have any cardiac symptoms of note. She's off a diuretic therapy, and she's feeling a whole lot better. So I think this case shows the potential role that different imaging modalities can play in your assessment of patients who you're considering TAVI in or surgical valve replacement, how we can use these different modalities to assess the severity of aortic stenosis and to plan the procedure, and how we can potentially not necessarily use all these tests, but use the right test for the clinical question at hand.
That's excellent. And indeed illustrated very well how to use in a stepwise every imaging technique that you have available in your clinical practice. We have some questions from the audience.
Yeah.
And that relate to this topic. One, for example, is the use of delayed enhancement and MRI in patients with heart failure. Mm-hmm. The absence of late enhancement excludes completely the ischemic etiology. How confident are you that maybe that patient cannot have a coronary artery disease?
Yeah, I guess so. It's always possible that the patient has critical left main stem stenosis and disease in the right coronary artery causing the global ischemia and LV dysfunction. It has to be pretty severe stenosis to get that at rest. And of course, this patient underwent coronary angiography as part of the workup for the TAVI and had non-obstructive coronary disease. So in this particular patient, yeah, I was absolutely confident. I think more generally, that's an interesting question. Do you feel the need to do another test when you see that in patients? And to be honest with you, I don't, because I think the ischemic cardiomyopathies that I've seen generally have some features of myocardial infarction, either on the scan or on the ECG or in some way that point you towards that. There is the danger that you miss the odd patient, but I think the added value of sending all the patients who have a normal MRI scan to the cath lab, I think, is small, but it's a point for debate.
Yeah. And the other question is, since MRI is considered the reference standard for measurement of the right ventricular function, what about the assessment of the right ventricular function in this patient?
Yeah, that's a great question. So right ventricular function, I mean, there is some nice data, really echo data actually, from Philippe Chénereau and his group, looking at the importance that right ventricular dysfunction has in terms of your long-term prognosis after TAVI. And this patient's RV function was basically preserved and normal. But I think if you see RV dysfunction in someone with severe aortic stenosis, that's telling you that that patient is quite far down the road of cardiac decompensation and needs prompt assessment and treatment.
One of the etiologies, for example, which can make left ventricular and also right ventricular dysfunction is the presence of amyloidosis. And we have now more recent evidence that indeed significant proportion of patients who have a severe aortic stenosis may have cardiac amyloidosis.
Yeah.
What is your opinion about the use of nuclear testing in these patients?
Yeah, this is a really interesting topic. So there's been some data over the last year or two looking at the TAVI population in particular, and these elderly population of patients seem to have quite a high prevalence of cardiac amyloidosis, up to 16% in some studies. So that's a lot of the patients coming through the TAVI MDT that potentially have amyloid, and it raises a lot of questions. You know, should we be looking out for this diagnosis more carefully in our assessment of the patients? If you find it, what should we do? Should we do TAVI in these patients? Are these people that are going to respond well to having a TAVI? And of course, now we have different treatments that have emerged, particularly for TTR amyloid. And so then, you know, should we be starting these patients on treatment before we consider TAVI, etc.? So this is a big question. And as we are considering intervention in more elderly patients, then I think we need to think about amyloid. It needs to be in our differential diagnosis. We did consider it in our patient. I mean, she was elderly. She didn't have too much in the way of left ventricular hypertrophy, but she clearly had LV systolic dysfunction. And we were reassured that there were no cardiac features of amyloidosis when we did the late enhancement. And you talked about nuclear tests. So we can use SPECT imaging with bisphosphonate tracers. These are bone tracers that have been around for a long time. And they can differentiate TTR from AL amyloid, based on the fact that there's often calcification associated with TTR amyloid. So we can start to use SPECT imaging to differentiate the two forms of amyloid, and also as a sensitive tool to pick up TTR amyloid. So I think it needs to be on our radar, is the short answer. We need to at least be thinking about that in our patients going through the TAVI cohort, particularly the people with low flow states and excessive hypertrophy, etc.
Indeed. So you know that for patients who have a classical low flow, low gradient severe aortic stenosis, there can be something else in addition to the severe aortic stenosis, and you can use the different imaging modalities to answer the clinical question that you have. First of all, which is the etiology of the left ventricular systolic dysfunction? Is there also right ventricular systolic dysfunction or not? And later on, which other imaging techniques you can use in order to accurately assess the severity of the aortic stenosis. But echo can give a lot of information as well. And I think that Mark Monaghan has a very nice case to convince us that echo still is not dead yet.
Thank you very much, Victoria. Yes, I've actually given the title of my presentation a slightly provocative title, because I've said not dead yet. And, you know, echo, of course, I think everyone would agree, and Mark showed it nicely in his case, that echo is pivotal in terms of the diagnosis of aortic stenosis. But in terms of actually guiding a TAVI procedure or even the workup of it, many centres have moved away from echo now and they're using CT. But of course, we all know that there are patients in whom it's not possible to do a CT. And I think it's useful to have echo as another modality that you can use. And indeed, since we started our TAVI program at King's back in 2007, we've been using 3D TOE for sizing the majority of our valves and only really use CT when we can't do TOE. So I'm going to take you through some things that we can do with echo so you can be aware of that. So these are my disclosures. And we're going to start first of all, straight with a case like Mark did, and this is a very typical TAVI referral, an elderly male patient who had previously been very active. He was able to go out shopping, do his gardening, but more recently he'd presented with some syncopal episodes and also some dyspnea. So he went to his GP, who heard a systolic murmur, and therefore referred him to us for a cardiology opinion. And of course, the first thing that we did was a transthoracic echo. Now, unlike Mark's patient, this patient clearly had severe aortic stenosis. As you'll see, there's good left ventricular function, and there were very high gradients. So a peak gradient of 90, a mean gradient of 55, and a valve area of 0.85. So no discrepancy, no question of low flow, low gradient aortic stenosis. However, the patient did have a very high Euroscore, so clearly was not going to be a surgical candidate. And so it was decided at the MDT that this patient would go down our TAVI workup and referral pathway. So let me start by showing you the transthoracic echo, which you can see here, the parasternal long axis view. You can see that there's considerable left ventricular hypertrophy. The aortic valve is clearly very calcified and immobile. But more importantly, there is extensive calcification extending down the anterior mitral leaflet into the LV outflow tract, and you can see how small the LV outflow tract is. There's quite a septal bulge, which is not uncommon in elderly patients with aortic stenosis. So that's a worrying feature which we'll return to in a minute. Here is another transthoracic echo image showing that he's got mild to moderate aortic regurgitation, and you can see the left ventricular function appears to be good. This is the continuous wave Doppler through the aortic valve with very high velocities confirming the presence of severe aortic stenosis. So, as I've already mentioned, we tend to do most of our valve sizing using 3D TOE, and in this particular patient, and I'll hopefully have the opportunity to talk to you a bit more about that in a minute. The basic principles are almost identical to the way you do it with a CT. You generate some multiplane reconstruction and a transverse view just beneath the aortic valve leaflets at the level of the virtual annulus, which you can then trace around to calculate the virtual diameter, which in this case is 24 millimeters. The sinuses were 34 to 33 millimeters, and the left main coronary height was 11 millimeters. So in this particular case, there's adequate room in the sinuses for a 26 millimeter valve, which is what you would normally do with a degree of oversizing. And so that's what we decided to implant in this patient. Now, I should add that, of course, there are different considerations in terms of not just what valve size, but what valve type one should implant. And in a patient with this kind of left ventricular outflow tract calcification, where there's a high rupture risk, one might consider doing a self-expanding valve, which undoubtedly would have the risk of more paravalvular regurgitation, but less rupture risk. Now, for a variety of reasons at the time we did this particular TAVI, that wasn't an option for us, and so we decided to go ahead with the balloon expandable sapien valve. But we got even more worried when we looked at these additional TOE images. Because this is an Xplane or transverse biplane view in the LV outflow tract, and now you can see this ridge of calcium sticking down beneath the aortic valve in this very small LV outflow tract. And if we move on to the 3D TOE images here, and I rotate this round, again, you're looking at the LV outflow tract here. You can see this very calcified area with a sharp edge on it. This is the aortic valve here. So there is some definite risk here, and the most obvious risk, as I said, would be paravalvular regurgitation with a self-expanding valve and a rupture with a balloon-deployed valve or balloon-expanded valve. But as you'll see, that's not exactly what happened. So because of the risks in this patient, we decided to do this TAVI case under TOE guidance. And as you know, that with a balloon expanded valve, it's deployed under rapid pacing. So just to orientate you, here is the balloon on the delivery system. The left ventricle now is on this side. Here is a calcified aortic valve, and this is the aortic root and the ascending aorta going up here. So if I start this off, you'll see the rapid pacing. The balloon is starting to expand now, taking the valve with it. And then as we get later into the sequence, you can see that the balloon bursts. And so that balloon has burst there. And when we move on to look at the immediate post-deployment TOE images, you can see that in fact what's happened is the balloon burst before the valve was fully deployed, and we now have an under-deployed valve with significant paravalvular regurgitation, which you can see here. So that's not a good thing. So now, time for you to do a little bit of work and see what you think we should do next. So you're in the cath lab, this has happened. What would you do? A, call a surgeon. If you think we should have post-dilated, then vote B. If you do a valve-in-valve procedure, then vote C. And if you just accept a suboptimal result and put up the aortic regurgitation, then D is the one you should vote.
Great. That's a very difficult case, I think.
And the problem with these things is, as I said, you have to, you don't have time to think about it for that long. You've got to make a decision reasonably quickly. Because
you have to weigh also the risk of annular rupture in those cases. Yeah. So let's see what the audience has answered. So 56% post-dilate and 31% valve-in-valve procedure.
Well, that's very interesting because, traditionally, you would think that a valve-in-valve wouldn't work that well for perivalvular regurgitation. It's good for transvalvular, but not for perivalvular regurgitation. But actually, we've used it quite successfully in many cases because the cuff around some of these valves, in particular the sapien valve, actually is quite good at sealing off the area around the valve. But this patient, we'd already had a balloon rupture, so that may not have worked so well. But having said that, what we decided to do first of all was to post-dilate. So let me show you what happened. So these are the Xplane images during the post-dilation. You can see there's the balloon expanding during the rapid pacing, expand the valve, and then it bursts again. And the reason for that is, of course, that spike of calcium in the LV outflow tract is still there, and it bursts the second balloon, as we can see. And it won't surprise you to know that when I did the echo, it showed, again, significant paravalvular regurgitation. I don't know whether the interventional cardiologist didn't want to believe me or just didn't believe me, but anyway, before we did anything else, they decided they were going to do an angiogram, and that indeed confirms what I'd said on the echo, that there was significant paravalvular regurgitation. And interestingly, you can also see the spike of calcium there in the left ventricular outflow tract. So, time for you to do a bit more work. So we're in the same situation as we were before. So what would you all do now? Would you call a surgeon, which is A, B, post-dilate again, C, now do a valve-in-valve procedure, D, accept the suboptimal result, or do something else like a percutaneous closure of this leak?
Wow, that's a very challenging question and a very challenging scenario, because you have to be very experienced to decide upfront or there in that moment what you are going to do.
But we have a great audience, and Victoria. I'm sure they'll come up with a good answer.
I'm sure that they will come with an excellent answer. But for me, I really don't know what I would recommend. It's very difficult because you have that spike there that is not going to move. Yes. And if it moves away, then we have a real problem. So while we are waiting for the answers of the audience, what would be your opinion, Mark?
Well, I think, as you say, it's difficult. The chances of getting lucky third time round and deploying the valve seem small. And I think you're likely to burst the balloon again, and with the potential for stroke and complications associated with that. So I think we've had 2 goes. That's probably enough. I think the percutaneous closure is quite attractive. Whether we think about doing that now after a long procedure, that's something to think about, but it's certainly an option down the line. I don't think we're going to call a surgeon. The patient has already been turned down for surgery, so yeah, I think I'm leaning towards E. We'll see what the audience think.
So the audience thinks that is 46% for them. They would say valve-in-valve, and 28 will attempt a paravalvular closure. What did you do, Mark?
Well, we went for the percutaneous closure because, as Mark quite rightly said, we've blown up a valve twice in this balloon and it's burst both times. So I think it's very likely the same thing will happen the third time, and we just risk complications. But the patient had been through a lot that day, and we'd all been through quite a lot as well. So we decided to bring the patient back in a couple of weeks and to attempt a percutaneous closure. So this is the TOE image I got a couple of weeks later when we were doing the percutaneous closure. You can see there's still significant paravalvular regurgitation. And so just a couple of images during the procedure. So on the left-hand side, this is this procedure, as I should say, was 3D TOE guided. So here's the 3D color of the paravalvular leak, and now we've got the guiding catheter through it. Let me just play this loop here. So you can see there's the guiding catheter positioned through it. And then in the next image, you can see here is the closure device before it's pulled back and deployed. So the next stage of the procedure is to pull that back into the leak, and which we did successfully. And then this is the post-procedure images. So here is the closure device, and you can see that we've ended up with negligible paravalvular regurgitation now, so a very gratifying result. The patient did extremely well, went home a couple of days later and is still doing fine.
Excellent. So that is really for very skilled labs, I think. It's not that common practice, right?
It's not. It is a little bit more complicated, but actually, with some of the modern imaging modalities that we have available to us, like fusion imaging, because the difficulty with something like this is actually getting across the aortic valve in the right position. So for this kind of thing, we would use fusion imaging where we can combine 3D and 2D echo with the fluoroscopy, and because I can see on the echo exactly where the leak is, I can put a marker on there, and then the interventional cardiologist can try and get their guiding catheter through that particular point. So that actually made doing this particular closure much easier than it might have been otherwise.
That's very good. And indeed, as you have heard, fusion imaging is another imaging modality that is coming into the clinical field, where you can overlay echocardiographic images on fluoro and help sometimes the communication, most of the time the communication between the interventionalists and the imagers. So I have one question for you regarding what would be, for example, the quantification of paravalvular regurgitation. How do you do it? Because sometimes it's difficult. And is there any other imaging technique that can help? What do you think? What do you think, Mark?
Well, you know, it can be very, very difficult to do, because you can end up with multiple paravalvular leaks, not just the ones, not just a single one as you might do in a native valve. And it depends. In the cath lab, as I was describing there, you often have to make a very, very quick decision. Because the interventional cardiologists, they're lovely people, the ones I work with, but they're not very patient. And they want to know quickly whether we've got to do something or they can go home and have a cup of tea. And so in the cath lab, what I like to do is to look in a transverse view just beneath the aortic valve. Can I show an example?
Exactly, yeah,
okay.
Perfect.
So just one point to make, first of all, if I can bring this slide up here. So the conventional way, of course, is looking at the size of the curve flow jet, but all the same problems that we have when we're looking at mitral regurgitation also exist with aortic regurgitation. So the driving pressure really affects the length and the size of the jet. And so these patients often have very low blood pressure after they've had the valve implanted. So that's not the way to do it. And I think a pragmatic way of doing this, and we described this with Becky Hahn and Philip Pibereau a few years ago, is to look in a transverse view or short axis view, and this can be done from TOE if you have it available, or from transthoracic echo in the cath lab if you've got nice images. So you get a short axis view just beneath the aortic valve and the TAVI valve, and that's quite important. And then you can look at these multiple jets in the left ventricular outflow tract and summate them and look at them as a percentage of the overall circumference of the left ventricular outflow tract, the aortic valve. And so, in the interest of time, I won't go through the schema in detail, but essentially what we do is look at the percentage, and if you've got sort of 25% of the circumference of the left ventricular outflow tract where you can see colour flowing diastole, then that's important aortic regurgitation, and you know that patient is going to do very well, and you should seriously consider doing something about it. And this slide really from that publication shows you the principle, shows you the different echo views that you can do to use this and summate all these different jets that you can get, because they go every which way in this setting.
Interesting. And Mark, do you think that CMR could help, not in the acute phase, but at a later stage, to decide whether to pursue other therapies like a paravalvular leak closure?
Yeah, I mean, every now and then I think its role is when it's not clear on the echo for whatever reason. And I think in those patients where we're not entirely sure how bad the paravalvular leak, or indeed the native valve leak is, then I think MRI can provide us with a quantification of the degree of aortic regurgitation. And it does that in a slightly different way. It uses flow mapping. You just measure the forward flow up in the aorta and the regurgitant flow back down the aorta and work out the regurgitant fraction and volume, and we can use that to try and assess the severity of AR. So I think it has a role in patients where we're not sure. And as you say, it's not much use in the cath lab. That's bit late, impossible to do an MRI scan there, but I think if you've got time and there's a question, then you could think about using an MRI scan.
Good. So we see that paravalvular regurgitation is not a good thing to have, and you should aim for having the optimal resolve of the TAVI, and for that is crucial to measure accurately the aortic annulus. So one of the questions, Mark, that it comes always is what to use: 3D transesophageal echocardiography, CT, and what to measure. Do we measure the small diameter, the largest diameter, the area of the perimeter? Which is your tip and trick for this?
Okay, well, again, if I can show some slides
yes,
to illustrate it, it might be easier. But I'm going to start off with this sort of case here, which I feel a little bit guilty about showing with Mark here. But this is a patient where we really couldn't see the aortic valve very well because of flow masking and of the mechanical mitral valve. So we decided to send the patient for a CT because I couldn't measure the annulus size on the TOE, and the CT came back and told us that the annulus size was 21 millimeters. So we put in a 23 valve and ended up with significant paravalvular regurgitation. Now, as we've discussed, the point here is that it's not the modality that got it wrong. It didn't matter really whether we use CT or TOE. It's the level of expertise and what you're familiar with in your particular department. And I think there's a good case for departments getting good at doing both CT and TOE, because there are times when you can't always do a CT scan. So let me show you how we do it here with TOE. So this is a 3D data set. It's a zoom data set from the LV outflow tract until just above the sinotubular junction, obtained from a TOE, and this is standard vendor software. All ultrasound manufacturers have this. Now, in the interest of time, I'm just going to flick on a little bit here and just show you that what we do then is to, just as Mark showed you with multi-slice CT, is we do a multi-plane reconstruction. And what I'm trying to do is orientate this scan plane up the top here, so we're right across the aortic annulus. And so we want to make sure that it's right across the aortic annulus, just beneath the level of the aortic valve leaflet. So I'm going to move it down here, just so we're down beneath the aortic valve. And then we'll see the annulus coming here. So we move it backwards and forwards, checking we're in the right plane. And then when I'm happy about that, what I'm going to do is zoom in on this particular MPR, so we can then trace out this aortic annulus here. So once I'm happy with that, and again, let me just zoom on for a few seconds here, then we can trace this out. Now, we can measure the maximum and minimum dimensions, which is what I'm going to start off doing. And I like to do that because just by looking at the ratio of the two of them, that gives us an idea of how oval it is. And indeed, you can see how oval this particular annulus is. And then when we trace it out, what we're going to end up with is a measurement of both the area and also the perimeter, or the circumference. And of course, what we're trying to achieve is an estimation of what that will be when it's circularized by putting a TAVI valve in there. So we could work out what would be the diameter of a circle with the same area, or the diameter of a circle with the same circumference. I happen to like to use circumference because, as we've discussed, these are often very, very oval, and the more oval it gets, the smaller the area gets, but the circumference stays the same. And we can discuss that in a little bit more in a minute. So now what I'm doing is I've moved this multi-plane plane up above the aortic valve here, and I'm just trying to find the left main coronary artery, which we spotted here. So now we're going to align in this blue plane down here with the left main coronary artery, which you can see there. So we're just expanded out. So that's the left main ostium. Here is the aortic valve, and now we can measure the distance from the left main ostium to the aortic valve. And of course, we can apply exactly the same principle with the right coronary artery as well. So these are the measurements that we got in this particular patient. So the annulus dimension was 17 by 26. The circumference was 69, and from that, it's very, very simple. We just divide that by pi, and that gives us a virtual diameter of 22. Now, the sinuses were 33 by 36, and the left main was 16. So actually, if you go into the Edwards-Sapien lookup table with a virtual diameter of 22 millimeters, you've got two choices. You could either implant a 23 millimeter valve or a 26 millimeter valve. Now, as you can see, we decided to employ a 26 millimeter valve because the aortic valve leaflets were not that calcified and the sinuses were quite capacious. So we had plenty of room and we thought the rupture risk was small. So that's what we did, and it was successfully done with no paravalvular leak at all. And if you'll just excuse me, I'll just show you this next slide. So these data are a little bit old, but I'm confident our practice is still exactly the same. So this is a series we published in JACE a few years ago of more than 250 patients, all sized by a 3D TOE. And as you can see, that the incidence of more than mild paravalvular regurgitation was only 3.3%. And that really correlates very, very nicely with all the series that have been published using CT. So, I think that makes the point that both Mark and I think have been making, that actually these modalities are pretty interchangeable, and what matters more is what you get confident with and get good at using.
Exactly. We have one question from the audience as well, and you presented a case on bicuspid aortic valve. You have presented a case on tricuspid aortic valve, but in bicuspid aortic valve, sometimes it's difficult to measure the aortic annulus. Any tips or tricks for you?
Well, so it depends what philosophy you abide to, because a lot of people think that with bicuspid aortic valves, you should aim for a supraannular implantation. So you might measure it slightly different and measure it slightly higher. I have to say, at King's, we tend not to do that. We measure them in pretty much in a standard way, but we do recognise the fact that actually, with bicuspid aortic valves, the risk of complications is actually not just theoretically, but is really greater. So you can have more of an instance of aortic rupture. And more of an instance of paravalvular regurgitation. So we think very, very carefully about where we're going to position the valve, what type of valve that we're going to use, and also our sizing. And if we've got any doubts about it, then rather than just jump in and do that, what we will often do is we think we've worked it out, but we'll just do a balloon sizing in the cath lab at the last minute, just to make sure, see how the valve actually behaves when you inflate a balloon across it, to make sure that we're going to be safe before we actually do the final implant.
That's very important. In your institution, in your center, how do you approach these patients? Do you check, for example, to the different anatomy that we can have, whether they have raphe or they only have the two leaflets?
Yeah, I mean, I think in some ways that is a controversial part of my case that I skipped over a bit. But I think it's controversial for two reasons. Like TAVI and bicuspid valve patients, I think we pause a little bit. I think you can do it, but I think we at least pause when we're dealing with the bicuspid valve. And actually, CT calcium scoring in patients with bicuspid valves perhaps is not quite as robust as it is in trileaflet valves. That aside, I think in the case that we saw, that was a functionally bicuspid valve. The patient had preserved sinus architecture. And I think the issues and concerns around sizing of the valve are probably not as applicable to that patient as they would be for someone who had a kind of true bicuspid morphology with abnormal sinuses, etc. So I think we still have to take it on a case-by-case basis and look at the patients individually, but certainly pay a bit more attention when we're dealing with a patient with a bicuspid valve than we do perhaps with the trileaflet valve, which is a much more straightforward care pathway for the patients.
But what we agree is that three-dimensional imaging techniques should be the most important imaging technique to assess the aortic annulus and to size the valve.
Absolutely. It's a three-dimensional structure, and we should definitely not use two-dimensional imaging modalities. And I think that's why echo originally got a bad name in this area, because people started doing it with 2D TOE. We were actually very lucky at King's. It was serendipity that we started our program in 2007, which is exactly when 3D TOE came out. So we started using it straight away and have never done it any other way. But I know that other centres didn't, and then didn't get quite such good results. So 3D imaging, whether it's CT or TOE, is the way forward, absolutely.
I like your case, Mark, because that showed that on CT, if you take a 2D measurement on CT, that you run into exactly the same problems as you get with the 2D measurement on echo.
Yes.
And as we've discussed, it's a 3D measurement that's important, not necessarily the modality that you use to make the measurement.
Yeah, yeah.
And Mark showed a case with left ventricular systolic dysfunction, and he opted for CMR to assess a little bit more the etiology of this heart failure patient. But for you that you have shown the value of echocardiography, that is a valuable technique for patient selection and also guidance of the procedure. In terms of patient selection, what is your opinion about the use of global longitudinal strain to assess these patients? This was one of the questions posted by the audience.
Yeah, I mean, there's a lot of data emerging now that it is a very powerful predictor of outcomes, not just in TAVI patients, but in patients undergoing conventional surgical AVR. But it's a long stretch from saying, okay, this patient may not do quite so well long term, to actually turn them down, because a lot of these patients are really elderly, and we're not necessarily expecting that they're going to be living another 10, 15 years. So it's part of the overall picture. And I was thinking, when we were talking about the high percentage of patients that present with amyloid, of course there are some echo indicators, including the pattern of GLS, which might give you a clue. So, you know, given the high incidence, that maybe we should look at the distribution and see if there's evidence of apical sparing as we're doing the echo in these patients, and then say, well, okay, this should be investigated by more sophisticated imaging techniques to see if, well, that's really there. So GLS definitely has a role to play, but from a purely practical point of view, I think we're a bit of a way from saying, well, we're going to turn this patient down because their GLS is 15% or whatever. So.
But exciting, eh? Who could imagine that aortic stenosis would give so much play for all the imaging modalities that we have right now? And an important field also is in TAVI, if we go to lower risk patients, what should we do? How do we assess those patients? What are the issues that you would do different in those patients?
Well, I think the first thing is, as we go into lower risk patients, I think the issue about TAVI durability becomes more prominent. So if we're putting a TAVI in an 80-year-old patient, there's a very high probability that they're going to outlive their valve. If we're starting to think about putting it into younger patients, then the durability becomes more of an issue. And I think that's something we need to think about carefully before we just extend it into all patients, all comers. And that data will come out over the next few years. And at the moment, it looks pretty good. But I think we need to know that before we start giving it to everybody. Having said that, there will be patients that are younger that we think that TAVI might be a more suitable operation. Perhaps they've had a previous bypass operation at a young age. And I think in some ways it's kind of easier for them because they're more likely to have favourable peripheral vessels, and we're more likely to get good imaging data from them. So, you know, and the interventionalists are going to be pretty confident they can do the procedure at very low short-term risk.
But of course, you know, in those patient groups, the bar has been raised because surgical AVR is, you know, is by definition a very, very low-risk procedure, and so we have to make sure that our TAVI procedure is perfect. And so no paravalvular regurgitation, absolutely perfect sizing, really low-risk complications. So I think it actually only puts even more pressure on us as imagers to get it right and to plan for the procedure more in that patient cohort.
And not also only for planning, I think also for follow-up.
Yes.
Because echocardiography will be the main technique to follow up these patients, but there is the rise of the CT showing some abnormalities, and even you have experience as well. You presented at ESC work on the use of nuclear techniques as well.
Yeah, that's right. So, I mean, echo is, you know, as usual, the go-to first line imaging test, but of course, it only detects the degeneration of the valves right at the end stages when you have functional problems with the valve. And so there's interest in anatomical tests like CT in detecting earlier stages. We can find pannus, we can find calcification of the valve leaflets, and we can find thrombus of the leaflets, an interesting area with TAVI. And then we've been looking at a nuclear technique with a tracer looking at calcification activity. And that looks very promising. We can really identify the early stages of degeneration of these valves, predict the valves that are likely to fail in the future. So I think this is just, as you said, this is an exciting area to be in because A, there's a lot of interest in aortic valve disease, and B, there's real opportunity to make a positive impact with new approaches, new techniques, and there's a growing population of patients that need treatment. And I think you know, it's certainly an area I want to stay involved with because it's moving quickly and it's highly exciting.
Great. So I think that we have had an excellent webinar. There are still many questions to be answered that probably we will need more webinars in the future to continue discussing. And we are now approaching the end of the webinar. And I would like to close this session by reminding some of the key messages for you in daily practice. We have learned that in patients with aortic stenosis, echocardiography is the imaging technique that we use in clinical practice to approach these patients initially, but there are specific clinical scenarios where CT and CMR can help to refine the diagnosis, and also nuclear imaging techniques, as we have mentioned. Three-dimensional imaging technique is key in the evaluation of patients for TAVI because it gives us accurate sizing of the aortic annulus and selection of the prosthesis to avoid paravalvular leak later on, and give us also information, particularly CT, for the procedural access, whether it's transfemoral or non-transfemoral. During the procedure, echocardiography ensures the results are good, and if there are complications, then it can help to diagnose the complication and decide the treatment, and in case of later complications, for example, CT can also be of help, and also CMR when we have doubts on how severe the paravalvular leak is. We will now close the webinar. Thank you, Dr. Monaghan, and thank you, Dr. Dweck, for these excellent cases. Thank you to the audience for attending the webinar and posting the questions, and we hope you enjoyed the time with us. You will be able to, again, view this webinar offline in a few days on the EAC website. Thank you very much.